What if I told you that the most important prescription for your health isn't one that I can write in my office? What if it's the safety of your neighborhood, the quality of your child's school, or the fresh food available at your local market? Welcome to Prescribing a Healthier Future. I'm your host, Dr. Akilah Weber Pearson. As a medical doctor and a California state senator, I get a unique view into the health of our state. On this show, we go beyond the headlines to talk about the larger health impacts on the people of California, the work that I'm doing in Sacramento to address them, and how, together, we can prescribe better, more effective solutions for our communities. Today, we're exploring an idea that is revolutionizing how we think about health, the social determinants of health. These are the conditions in the places where we live, learn, work, and play that fundamentally shape our health outcomes. And I couldn't think of a better person to explore this with. Our guest today is a mentor, a pillar in the San Diego community, and a national leader in the fight for health equity. He has been on the front lines for decades, witnessing firsthand how these social factors impact real people every single day. Please welcome the incredible Dr. Rodney Hood. Before we dive in, if you believe in the importance of these conversations, please take a moment to like, subscribe, or follow right now on whatever platform you're using. It really helps us reach more people. Dr. Hood, thank you so much for being here.
Dr. Weber, thank you for having me.
Of course. This is really an honor for me because you truly are an expert in this field. You've done a lot of work, not only clinical, but research to look at some of these things dealing with the social determinants of health. So, one of the things that really strikes me every time I hear this statement, your health is more determined by your zip code than your genetic code. Mm-hmm. And I think that hits me, and it really is very remarkable to people because most people do not realize that the majority of what happens to them as far as their health and their health outcomes is actually determined outside of a doctor's office. And even though here in the United States, we spend billions on healthcare, we still rank as one of the lowest in the developing countries in terms of our health outcomes. And a lot of that has to do with the social determinants of health. But can you help us understand what social determinants of health is and how that impacts our daily lives?
Yeah, you're 100% right. Social determinants of health are really situations that we find ourselves in dependent upon where we live, where we work, where we play, where we grow, where we spend most of our time. And what we're finding out is that the environmental factors and the factors that you encounter in your living environment affect your health either in a positive way or a negative way, even more so than the doctor's office. Mm-hmm. You mentioned before 80%. Some people say it's 90%. Outside of the doctor's office affects your health. Mm-hmm. And so it's important that people know that because whether they're visiting the doctor or not, there are things they can be doing that can improve their health status as they move forward.
Mm-hmm. And I think it's also important for people to realize because not only are there things that they can do to improve it, but there are also factors that they may be unaware of initially that are having a negative impact on their health and ultimately their health outcomes. So I want to talk a little bit about food. Mm-hmm. We often talk about that, you are what you eat. And we're seeing that a lot in terms of the disproportionate rates of certain conditions, obesity, high blood pressure, diabetes, all of which are oftentimes linked to the foods that you eat. How does food and access to food play into the idea of social determinants of health?
So I think it's one of the critical factors. And let me address it from an individual perspective and from a system perspective. What we mostly hear is from an individual perspective. We should eat healthy. What does that mean? We should take our mind and body. We should exercise. Eating healthy means trying to eat the food that's most nutritious for us. When I went to medical school years ago, we used to talk about a balanced diet being 3 times a day with red meat, etc. What we now believe, as close as you can get to a plant-based diet, is probably the most healthy diet. Now, most of us are never going to reach that, and I'm not saying you shouldn't try. But what it means is try to eat some plant-based every single day, maybe once a day, a nice salad, and maybe have something healthy in the morning like oatmeal with low-fat milk. And then your main meal, you can have the protein. On a collective basis, a system is dependent upon where you live, and this is where the social determinants happen. What I just said may be easier for others to do, dependent upon where they live. So if you live in an area where sometimes we call them food deserts, where you don't have access to fresh fruits and vegetables, you have more access to processed foods that you get at fast foods. Those have been shown to be unhealthy. So we should encourage our community to get in a supermarket or something like that where they actually have fresh foods.
Yeah, I'm glad that you brought that up because, USDA Food Access Research Atlas actually showed in 2019 that about 17% of the U.S. population live in low-income areas that have more than half a mile to their nearest supermarket if they live in an urban area, or 10 miles to the nearest supermarket if they live in a rural area. And so when we in the health profession have patients and we say, you need to work on your nutrition, you need to, you're getting overweight or you have obesity or you're on the track for diabetes and you need to eat certain things, I think in the health profession, we have realized a while ago that we can tell them that, but if they don't actually have access to those foods, those healthier foods, then it's hard for us to change their behaviors in that way because they just don't have access to those things. It's interesting because when you look at certain communities, like the community in which I grew up in Oak Park, Southeast San Diego, we don't necessarily have the same amount of grocery stores that you would find in a place like La Jolla. But we do see now that the community itself are coming out saying, maybe we can do more community gardens. Maybe we can have farmers markets where they come into the community one day a week to provide those fresh fruits and vegetables that the community needs that they just do not have the access to.
Yeah, absolutely. And I can tell you, I've lived and I've also worked in Southeast San Diego over the past 50 years or so. And I have seen some improvement in that when the Jacob Center came in, they brought in food for less, which was helpful, but certainly wasn't the solution. I've been involved in an organization that's been supporting projects that actually teach folks how to do their own garden. You're familiar with Diane Moss and Project New Village, which is actually building a building and starting a program to teach folks in the community how to build their own garden or grow their own food, and also start a food center where you can get fruits and vegetables. Maybe I'm jumping ahead to solutions, but that's what's needed in these communities.
Yeah. And I think that as a legislator or for those that make policies, whether it's on a local level, a state level, or the federal level, when we're talking about bringing resources into certain communities, it's extremely important that we look at those communities that have been historically overlooked or underserved to ensure that they have the basic necessities like a grocery store that provide your fresh fruits and vegetables. that other communities have an abundance of. I want to now move to housing and health. Homelessness, people who experience homelessness have been shown to have a lower life expectancy. For example, the National Health Service on the Homelessness Council in 2019 showed that the average mortality age was around 42 to 52 for people who are experiencing homelessness, compared to 78 years for the general population. How does housing instability, or for someone who is currently unhoused, how does that fit into the social determinants of health? How does that ultimately play out in impacting that individual's or that family's health and their health outcomes?
Yeah, you just pointed it out. I am been on the board of the Alliance Healthcare Foundation for the past 12 years, 15 years. And when I first got on the board, it was focused on the disease of health and dealing with the underserved community, trying to get their diabetes and hypertension and those types of things. What we discovered was if you're not really addressing the social determinants, that it's going to be difficult to improve, and the data shows that. So over the past 10 years, they've taken some of their portfolio called impact investment, focused on housing. So they're actually giving low-cost loans to various developers that are developing low-cost housing in the low-income areas. One of them is Bethel AME Church with Pastor Avon. I was just at his new development. I think it's 24, 26 units right in southeast San Diego. That's critical because, as you said, the unhoused don't live as long. So there's a pecking order. If you're housed in an area of low income, the life expectancy is less than somebody who lives north of 8. If you're unhoused, it's even worse. So housing and fresh food, very important.
I know that that is often something that like physicians in the emergency room or internal medicine physicians look at a lot, is whether or not a person is housed. It's really hard to tell someone to take insulin for diabetes when you have to have a refrigerator to keep your insulin stored. It's really hard to say take certain medications if you're living on the street and you're moving from place to place to place every day or every other day. And so those are things that we all have to realize in terms of how do we help those who are unhoused or have housing instability, how we can keep them housed, and that will actually create a better health outcome for them. Another issue that people don't necessarily often link to health and health outcomes is transportation. So it has been noted in the American Journal of Public Health, actually in 2020, that about close to 6 million Americans delayed their medical care in 2017. So this was pre-pandemic due to lack of transportation. And I remember when I was a medical student and a very, very early resident, we would always talk about like the non-compliant patient. Either they don't take their medications, or they don't come to the appointments, or they're late, right? You have that cutoff time. And then we realized, well, sometimes people are late or they don't come because they don't have transportation. So can you speak a little bit more about how transportation and having access to that plays into the whole social determinants of health factor?
Transportation is critical. In 2012 to 2015, the group I was involved with, the Multicultural IPA, actually got a grant for 3 years to look at improving. Actually, the grant was to decrease cost of individuals in the low-income area who were high utilizers. And we put together a intervention team that included physicians, social workers, nurses, and community health workers. And over a 3-year period, there was a significant decrease in ER hospital utilization, saving over $15 million with an investment of $1.3 million. How did we do that? When we looked at the data, the most significant thing we did was help them with the social determinants of health. And at the top of the list was transportation. These patients had problems getting transportations to the doctor's office, to the grocery store, to whatever they needed to do. And when we put that team together, we were able to hook them up with appropriate transportation. There are lots of resources out there to help them get transported, but many of them had no way to connect to that. So transportation is key. There were a list of things that we did, but transportation, improving transportation for those patients, for their daily needs, for their doctor's visits was key in improving their health.
Yeah. You know, San Diego is a very interesting city in the way in which it is laid out. It is not San Francisco. It is not a New York. It is not a Chicago where you can just walk a block and, you know, get on your public transportation. And so we in the political space often talk about the last mile traveled because, and that is oftentimes the last mile to get to your home or to get to your job from the place where public transportation would drop you off. And so it's really been very heartening to see that conversation happening a lot more. And recently there was a grant that San Diego was awarded, and it will be happening right in the Southeast San Diego area where they will have these small units help with that last mile travel. So to pick someone up, to bring them to the trolley station, pick someone up, to take them to the bus, and vice versa, so that they can get to their appointments, they can get to their grocery stores, because transportation, you know, is an issue, and people may not realize it because some people have cars, but not everyone does, and not everyone lives or is able to easily walk to the trolley station or the bus station.
You know, there's an example of a patient during that time who had transportation problems. He was a quadriplegic in an electric wheelchair. He was his electric wheelchair broke down. He was on the second floor. And basically, the health insurance company kept saying they were going to repair it, but didn't. So how did he deal with it? When he needed to get out of the house, he'd call 911. The ambulance would come, take him to the ER. He was always saying that he had a urinary tract infection. Stop off, get him something to eat.
Wow.
When we and the cost to the insurance company was extravagant.
Exactly.
They didn't understand why. We got them not only to repair the wheelchair, but get him a new wheelchair, and the cost went down.
Right.
His health improved. So transportation is key.
Yeah. I am going to move into the historical concept that has caused some of these factors to disproportionately impact certain people in certain neighborhoods than others. And so I know this might be a little heavy part of the segment when we talk about some of the policies that were actually put in place here in California that caused certain communities to have higher rates of environmental toxin exposure, to have lower quality education schools, to actually be cut off and not have some of the resources that other communities have. So, you know, we can bring this back to San Diego. I was looking at the map the other day, looking at life expectancy, and some people may not know that, you know, depending on your county, you can go to your county's public health or health and human services website, or you can definitely do it at the state, and you can type in your zip code and that will give you your life expectancy if you're born there, which should not happen in this state or in this country. But when you look at the life expectancy rates here in San Diego, the differences are absolutely staggering. We're talking about like a 14-year gap, depending on where someone lives, just based on which side of the freeway you're born. We talk a lot about south of 8 versus north of 8. And some of those things are real. In San Diego County, life expectancy varies by up to 12 and a half years between neighborhoods. So if you're in the university area, your life expectancy is around 88 years. If you live in Chula Vista, 75 years. Can you talk about the history of redlining and how that essentially forced people to live in certain areas that were then underinvested and ignored for so many years.
So redlining was something that took place throughout this country, not just in California, not just in San Diego. And basically what it was, first of all, poor areas for certain populations many times didn't happen by circumstance. It happened because of certain policies that were put in that disenfranchised certain groups. Here, African Americans, Hispanics, Native Americans. And redlining was if you were in a certain area, financial institutions would not value your property as high as others. And they wouldn't sell property to blacks outside of certain areas. So certain races that were redlined were forced to only buy property in certain areas. And when they did buy property, their property was devalued. That led to a huge wealth gap. That had other consequences because the area then, education is based upon property taxes. And the educational system was therefore less. The quality of education was less. People who had a higher education, people who graduated from high school and went on to college, lived longer than people who didn't. Why? They had better access to better health care. They had better jobs. So it created, if I can get colloquial, I grew up in Boston. And a friend of mine's, when I first met him, he used to say, "Are you po?" And I asked, "What do you mean?" Well, in certain communities, there's a difference between po and poor. Po is a permanent cash flow situation, and poor is a temporary cash flow situation. And most folks who were redlined were in the po. They were there. It was very difficult for them to get out. And the policies that were created, not only financial, but having to do with education, kept them in that generation after generation. So how do you overcome those barriers? And so it's not just a matter of giving them a little bit more money. It's a matter of changing policy to allow them to grow.
You know, it's interesting that you touched on the issue of education and property taxes and how those flow into the local schools, because we often talk about, or you hear people say, education is the great equalizer. But if you're starting from a point that is so far behind others based on the resources that you have at your school, it's really hard to catch up to allow for that to actually be the equalizer. And education, your education really is the foundation of where you can ultimately go and your health. So adults without a high school diploma can expect to die 9 years sooner than college graduates. And that's based on the Virginia Commonwealth University Center on Society and Health from 2015. And so, as you stated, it is known that if you have at least a high school diploma, but I would venture to say that today you need much more than just a high school diploma. But definitely if you have at least a high school diploma, you will live significantly longer than those that don't. And if you are in a community that has been redlined and your property values are low, then that is less money flowing into those schools to allow for adequate resources, adequate teaching, adequate mentorship and help, extra tutorial, all of those things.
Yeah. And let me bring this other uncomfortable issue up. We talked about your zip code and where you live, but also race is an independent factor. Okay? We can look at a zip code that is low income and the have a very diverse population there, Hispanics, whites, Asians, blacks. And if you look at the life expectancy of the individuals by race, there's a difference. And that has to do with the racism or colorism that takes place in certain communities much more so than other communities. And and so it just can't. I had one person when I was talking said, "Well, where you live will determine your outcome." And this was an African American. He said, "Oh, well, all I have to do is move to La Jolla." And I said, "Yeah, if you move to La Jolla because you can afford it, things improve. But if you compare your health outcome and your life expectancy now to the others in La Jolla, it's better than where you were, but not equal to theirs. Why? There's this chronic, indolent racism that takes place, and that can cause chronic toxic stress. We can actually measure that now. That is negative to our health, adding to hypertension, diabetes, etc. We've been trying to answer the question for decades why African Americans have higher hypertension than other groups. Okay? And there are many factors to that, but this chronic stress by chronic racism is part of it.
I'm glad that you brought that up because, I talk about that a lot in the realm of social determinants of health and the impacts to the higher rates of Black maternal morbidity and mortality. And the fact that when you look at those rates, it is independent of your socioeconomic status. You can be, you can live in a very low income area, or you can be a wealthy, successful person like, the Williams sisters and have significant challenges in pregnancy. And that is because we often enter pregnancy at a state where our bodies have been more chronically stressed, that are more weathered than others. And so if you can highlight just a little bit more about the issue of, or the impact of chronic stress that is due to racism, because that is something that you don't see, and typically we don't test for. You can go to the doctor and you can test your blood pressure. You can test for diabetes. You can test your cholesterol level. You can have all of those things be perfectly normal, but your body has still had significant impacts of that chronic stress, which may have some cardiovascular concerns, but I'll let you elaborate on that a little more.
First of all, what we're talking about is real. Okay, this is not just bringing up race to be talking about race and what you feel and what I feel. Okay, what we're talking about is very real and impacts our health, i.e., racism can cause bad health. I'm going to put a plug for an article that I just wrote. It's published in the Journal of Racial and Ethnic Health Disparities called An American Story of a Health System Dilemma, Slave Health Deficit and Post-Traumatic Slavery Stress Disorder, a long name. But it's a long article, but it goes off into the history as to what has brought us to this point in time. And we can now, there was actually a study done here in San Diego at Kaiser by Dr. Folletti on ACEs. That's adverse childhood events. And he looked at thousands of individuals who had gone to Kaiser who were now adults and looked at any traumas they had while they were a child and found that traumas such as violence and mental abuse, sexual abuse, all of those things, the more of those traumas you had, the more diseases you developed later in life. When you looked at the subpopulation there of Blacks and Hispanics, they had greater ACE scores than the whites. And then as we get older and continually deal with this micro insults and the infant mortality and the maternal mortality, that leads to chronic stress. So it's real. And I think that more so than other populations, we see it in African American population. And I think that's important because the issue is, what do we do about that? First of all, we need to recognize it and admit that it's real. And I think we need to start doing some behavioral health things that help diminish that.
Yeah, no, I think that is, you just hit the nail right there on the head. Recognition is key. Not pretending that it doesn't exist, not pretending that we live in a race-blind, race-neutral society, because when we do that, it really truly is a disservice to everyone. And we're unable to fix or improve on a lot of the things. And so want to move into some solutions to some of these things that we've talked about around social determinants of health. One of the things that really gives me hope is that a lot of these things can be changed. Communities can actually step in and start changing these things themselves. And I mentioned some of the things before, like having community gardens or, individual cities saying we're going to do farmers markets in some of these areas that don't have access to fresh fruits. But, Dr. Hood, you've seen some incredible transformations in when people start changing their focus and changing their investments. You talked before about community health workers. Can you talk a little bit more about that?
Yeah. And before I do, you mentioned colorblind. I tell everybody color blindness is a disease. It's not something that we want to do. The issue isn't trying to be colorblind. The issue is really recognizing the cultural differences and appreciating the cultural differences, seeing them and appreciating them. Community health workers. I call them in healthcare the secret sauce. I think we need more of them. I talked about the grant that the Multicultural IPA had called the Patient Health Improvement. And I said that we saw a return on investment 5-to-1, saving $15 million. And I would say the main secret sauce was community health workers. We hired community health workers that were in contact with these high utilizing patients every single week. They would visit their home, they were on the phone with them, so that as problems came up, they were helping them navigate it, bringing it to the providers, assisting them getting transportation, assisting them with food and those types of things. Part of the program was we tied up with a food distribution center. So if somebody had problems getting food, they'd help them get their food. They were not taking the medications like us doctors thought they were because they were what I call pill budgeting, okay? And we found that out. We would make sure that they got their medication. Most of that information came to us through the community health workers.
Right.
These were patients maybe that I was seeing once every 2 or 3 months. But the community health workers say, doc, you prescribe those medications, they're telling you because they didn't want to make you angry that they're taking it, but they're really not. So the community health workers really assisted us in getting the patients to not only navigate the system, but to become more compliant with the health care.
And when we talk about healthcare that is more patient-centered and more equitable and recognizing the diversity in our various communities, community health workers really do fill in that gap because they themselves are from the community.
Exactly.
So they help break down some of the cultural barriers, some of the language barriers, some of the trust barriers.
Absolutely.
Because many communities have a distrust in healthcare and healthcare providers. And so community health workers and having them and having a system that incorporates them into the healthcare system is definitely a vital component to deal with some of these things, because they may not invite you or I into their home, but they will allow someone from their community to come in who will be able to see, oh, you're really not taking your medication, or, oh, you don't have any food in your refrigerator. Those kind of things that we won't have the ability to actually see.
And I do have a concern because the grant I talked about was prior to COVID. When COVID hit, a lot of community health workers, because of COVID, went telehealth. And although COVID is ended, I'm still seeing that still taking place. And I'm hoping that, and I don't know about everybody, but I do think what was more effective is them having personal contact with the patient, going into their homes, finding out things in the homes that they wouldn't find out over the phone. But you're 100% right. When they're from the community, it builds up trust. Community health workers during the COVID pandemic, we had Equity Task Force, and we actually got a grant. And the secret sauce to that was the community health workers working with the community, getting them out to get tested, to show them where the resources were, helping them to maintain their medications. So community health workers, we need to find a way to integrate them into a health system, just like we have doctors and nurses.
Right. Yeah.
It shouldn't be through just a grant.
Completely agree with that. Also want to, since we talked about homelessness and housing, wanted to talk about some of the solutions that we could potentially do. You talked about it with Bethel here. And, here in California, we have often tried to take the housing first model, where we recognize that instead of putting up all these barriers for people to get housing, we should put them in housing and then help deal with some of their other issues. So, Orange County did an analysis and estimated that housing all chronically homeless residents would actually save them about $42 million every year, annually. Instead of implementing things that are less permanent, more transitional, that actually putting people in a home would save money. And we know from a healthcare standpoint, it would also reduce emergency room visits, lower Medi-Cal costs for the overall household. So how do you think a housing first model could potentially help?
Well, I think you summed it up. It's critical. You pointed out that without housing, they die between 42 and 52. Okay. And that's because of just putting them in housing, that improves. So I think that that's critical. So we need more solutions to affordable housing. And you're right, we need to break down the barriers to get them into the housing. And if you put them in housing, they need to have wraparound services that go with that housing, because just putting them in there and them not knowing how to access the services outside of that housing is going to be critical. There is we're talking about social determinants of health that cause health disparities. There was a recent study in the Journal of American Medical Association, I think in 2023, that said health disparities, I think it was the year 2018, were costing the system an extra $451 billion a year just because of the health disparities. So people say, well, where are we going to get the money for the housing? If you do that, you'll be investing and getting the savings. The savings in getting people healthy.
Yeah. It's interesting that you say that, because that is one of the things that I feel like I have said so many times in Sacramento. If you invest more upfront on certain things, preventative care, housing, knocking down some of these social determinants of health, at the end of the day, we will ultimately end up saving so much more money. And it's hard to get people that, to think that way, that look at spending 1 or 2 years out instead of something that's 5-10 years out that would ultimately save money for the state, save money for cities, and for communities.
Part of that comes from the financial structure of our healthcare system. Most insurance companies look at their return on investment in the next year or two. And many times patients are not staying in their plan for 10 years or more. So they're saying, if I put this money up front, I'm not going to get my return on. So part of it is the system. And we need to figure a way around that. But clearly there is saving. I told you about the small program that I had that saved $15 million over 3 years. And CMS only invested 1.3 million. So there's a huge return on investment.
Huge return on investment. Yes, definitely. I cannot believe how quickly this has gone. I haven't even gotten to some of the other things I wanted to talk about as far as some of the things we could do with, health-based clinics and schools and, the food is medicine movement and some of the bills that we've tried to do in Sacramento. So I'm definitely going to have you back, but really appreciate you coming in. You have dropped a wealth of knowledge for all of us today and really appreciate it. Thank you for sharing your wisdom. Thank you for being here. I think the takeaway from our conversation today is crystal clear. Our health is created in our communities and not just in our clinics. And the stability of our housing and the quality of our schools, the safety of our streets. We didn't even get a chance to talk about public safety, the availability of nutritious foods and the strength of our social connections. Every policy decision that we make, from zoning laws to minimum wage, from transit routes to park funding, is a health decision. And when we invest in our communities, we are not just improving lives, we are creating a healthier, more prosperous California future for all. The prescription for a better future isn't written on a prescription pad. It's written in the policies that we pass, the communities that we build, and the connections that we strengthen. Thank you all so much for tuning in to A Prescription for a Healthier Future. Thank you, Dr. Hood, for being here. If this conversation resonated with you, the best way to support our work here is to rate, review, and share this episode with a friend or colleague. And to make sure that you never miss a discussion, please follow, like, and subscribe on YouTube, Apple Podcasts, Spotify, or wherever you tune in. Your support helps us bring more important conversations to light. Until next time, be well.